Good afternoon. Welcome to Medical Grand Rounds. I'm Bob Wachter, Chair of the UCSF Department of Medicine. Today is a special day, actually for a few reasons, but probably the main one is it's the annual Reza Ganji Memorial Lecture, a lecture we've held for many years in memory of Reza, who was a spectacular student and resident in our program at UCSF and died far too young. We're here with many of Reza's family and friends. We really appreciate you being here. I'll say a word about Reza, and I think Alicia will as well. I knew him quite well. It's really one of the more memorable and remarkable folks that I've met in my career in medicine. Reza was a native of Iran. He went to secondary school in England, graduated magna cum laude from Berkeley, attended Harvard Medical School, and then we were lucky enough to recruit Reza to our residency in internal medicine here, where he was an outstanding resident. As a third-year medical student, he was selected for a Rhodes Scholarship, where he received 2 degrees in England, one from Oxford and one from Cambridge. Reza had a special interest and skill in ethics and policy, and really asking the hard questions in life. I think he would be having a field day today because a lot of those are being asked all the time, and I would have really looked forward to hearing what he thought about today's goings on. But he was astute, he was brilliant, he was iconoclastic, he was different than almost anyone I think I've ever met, but you always learn something in your conversations. With Reza, he was always provocative and interesting and fun to talk to. So I miss him very much, and we're thrilled that his family has allowed us to memorialize him this way and remember him on what is always a somewhat bittersweet day. The talk today is called Keeping Eyes on the Prize, Focusing on Healthcare Equity. And obviously the issues of healthcare equity are very much in the news, and something that we're spending a lot of time thinking about and working hard on to defend what are extraordinarily important values for all of us, including in our department and our programs, and recognizing that you can't wish away the challenges and problems that we have in healthcare equity. And I'm proud of some of the progress we've made over the last several years, and committed to continuing to make that progress, although the policy environment has become obviously much different than it was. I don't think anyone in our department has done more to lead our work in healthcare equity than our speaker today, who's Alicia Fernandez, who's really an expert in health equity and disparities, and has focused on it really through a number of lenses, including a research lens, really understanding the drivers of inequities and what we need to do to make them better. She's a professor of medicine in our Division of General Internal Medicine based at San Francisco General Hospital. She's also Associate Dean of Population Health and Health Equity in our School of Medicine, and the founding director of the Latinx Center of Excellence at UCSF. She's won all sorts of honors and awards. She's a member of the National Academy of Medicine, and she's now on the U.S. Preventative Services Task Force. I could go on forever, but I won't. Let us welcome Alicia Fernandez for today's lecture. Thank you.
Thank you so very much for that generous introduction, Dr. Wachter. I am very honored to be here, particularly honored to deliver a lecture in Reza's memory. I remember Reza very well. He was only a year behind me in residency, and we overlapped a fair amount, particularly for some reason. We overlapped when we were both at San Francisco General. And we would talk in the resident room. And I have a clear memory of several conversations that we had about patients in the ER. And to those conversations, he brought exactly what Bob has said, an incredible intellect, but also a breadth of interest, a breadth of intellectual approach, an emotional approach, appreciation for bioethics that was really very unique. I was terribly saddened when he died, and I think he would have been one of the generation, one of the leaders of our generation in medicine, beyond a doubt, an extraordinary man and extraordinary doctor. So again, I'm deeply honored to be delivering a lecture in his name. I have no disclosures. So this is a hard time to give a talk about health equity. It feels a little off. It almost feels beside the point, and that anything I'm going to say is just so out of date that why even bother saying it? I wrote this piece with my colleague Marshall Chin from the University of Chicago under the editorship of Dr. Bernie Lowe at the New England Journal. And when we wrote that piece a year ago, what we were mainly focused on was a decade of very slow progress on healthcare equity. And we wanted to talk about what we thought may be partly a detour in terms of where we are with healthcare equity and some conceptual confusion. And we also wanted to talk about the need to redouble our efforts in a particular line. So today, what I'm going to do first is just talk about the large current emphasis on health-related social needs screening, which is screening patients for needs like housing or transportation. And then I'm going to talk and why I think that has been both a good thing and potentially problematic. And then I'm going to talk a little bit about, do we know what to do for disparities reduction and improving quality of care? And then finally, I will just mention what I think are the three pillars that we need to go forward with in order to get to better healthcare equity. And those are the health system reorganization, changes in leadership, and above all, changes in payment and the regulatory environment. So I'm going to try to keep my comments brief, as I hope we can get to a conversation with Dr. Wachter and to your questions and comments. So over the last 10, 15 years, health-related social needs screening is booming. There's a huge increase that's driven partly by payers and accreditors and partly by health equity advocates. As of 2023, 83% of hospitals reported screening for at least one of these health-related social needs. Some organizations like CMS, inpatient quality reporting, mandates screening for at least two in order to get the better score. And the Joint Commission now has issued a certification for a health equity hospital or health equity health system that requires screening for 5 health-related social needs, and those are housing, instability, transportation, the ability to pay for utilities, food insecurity, and interpersonal safety. So this is an important growth, and it's been accompanied by an increase in supports. Many of the electronic health records now have fields where this can be filled in, be it on the inpatient side or on the outpatient side. And these data can be used to inform the care of individual patients, or they can be aggregated to use for advocacy or quality improvement, or for predicting groups of people who may need more supports. There's also been a growth in apps, software with bidirectional signaling to community partners to make the handoff more efficiently. And finally, there's over the last 5 years, I would say, maybe a little bit more, lots of organizations, both for-profit and non-for-profit, have sprung up in order to contract with health systems in order to navigate patients to social services, and in that way provide better linkage. So this is a good thing. And where did it come from? Why are we doing this? Well, one reason we're doing it is because of the incredible data that links absence of housing and food insecurity to two things: worse health outcomes and more healthcare utilization, incontrovertible. And the other is a conceptual issue. And that is that there has been this focus on the fact that as healthcare workers, what we are constantly trying to do is rescue people who are going downstream. And instead, we should, quote unquote, be moving upstream, which is to say, why are so many people landing in the river to begin with? So I think what many people have thought is that health-related screening could help us with these upstream effects. Unfortunately, I will argue that health-related screening is a downstream activity, that we capture people once they've already fallen through the cracks and are in our system, and that it's really a fundamental difference from investment in the social determinants of health. So let's unpack that a little bit. Health-related social needs screening happens on the individual level. As we said, it screens for those usually once they're ill and for people who have fallen through. And it involves relatively small amounts of funding in terms of connecting them with resources. At its best, however, it can connect an individual to food and housing. It can improve their lives, their health, and it can lower healthcare use. Well, what are social determinants of health and how do they differ? Those tend to be measured on the community level. We're talking about infrastructure, educational quality, degree of inequities, the built environment, housing opportunities, et cetera. Big ways in which society organizes itself. These, of course, are what shape patterns of disease and illness in a particular society. What diseases come to the fore and what don't. And these typically require massive investments in order to make a difference on the level of percentages of GDP. And in fact, as Elizabeth Bradley in her book, The American Healthcare Paradox, has mentioned, the OECD countries, the Western European countries, spend about the same that the United States does when you look at the combined spending of social services and healthcare services. However, they spend it on social services, and the United States tends to spend it on healthcare services. And as a result, they have, in their best, through these massive investments, somewhat healthier society with much less need for health service use. Okay, one can argue, I get that these are different, but so what? Why is it important to think about this? And why is, most importantly, the large emphasis put on this by payers and regulators potentially problematic? And I think that's because of the possible unintended consequences of focusing on equating the two and choosing to focus on health-related social needs. These can take time and energy away from healthcare equity efforts. Most health systems, even large, relatively well-funded health systems, typically have a small office of 2 to 3 people who focus on healthcare equity efforts, usually with not a lot of resources. It can confuse people for advocating for more money toward the healthcare system. You have to give us more money so we can do a better job of screening and a better job of connecting people to resources. It can, because of that, potentially divert funding from community-based organizations that could, at least theoretically, help people more efficiently, more cheaply, and perhaps even in a more appropriate way. It's also can lead to other forms of confusions. For example, I've now seen lots of articles where people talk about somebody having limited English proficiency or low health literacy as having a social determinant of health that would make them, that is problematic. Putting the onus more on the patient and less on the health system to become a health literate organization or to become an organization that really can deal with language access. When we privilege, for example, connecting people with resources once they're ill, we can simply substitute one person in housing for another person with housing. If we have a priority for patients who are in the hospital, well, that's great for our ill patients, not so great if you're someone else who needs housing and are not ill. And then finally, there's the famous bridge to nowhere, in which many organizations are doing the screening because that's what's required. What isn't required is actually addressing the social need or referring people to resources. So at its worst, health-related social needs screening can detract from health equity efforts. It can divert resources within healthcare organizations. It can cause a competition for scarce resources or no resources in a community. And it can paradoxically delegitimize needs of people beyond illness. After all, people who are not ill also need access to food, housing, et cetera. And it can be, and we can allied into a scenario in which those needs are considered less important. Some people say, no, no, no. Health-related screening constitutes a way station. It's the long road to healthcare equity. And what they argue is that health-related screening will lead to greater pressure to create resources, and that will lead to more investment in social determinants of health, like more investment in housing, a healthier population, and in the end, a US that looks like Sweden. I don't think so. I think it's more likely that it's something of a detour, that it creates wins for individual patients, which is of extreme importance. It creates wins for systems that are designated as health equity systems, but it distracts the focus from what I will argue is our main goal, which is reorganizing the delivery system for equity. It's also a win for a particular form of ideology, which says we treat everyone the same. We give everyone the same great care. And when they need more, we refer them out. And I'll come back to this concept because I think it's an important one. So what's my bottom line? My bottom line is that I'm happy we're doing the screening. I think health-related screening is a good thing. We should do it. We've been doing it at the General for over 20 years. It's good for our patients. Doing it systematically can inform our advocacy and inform our programs, and that's a win. On the other hand, I think it's really important that people not confuse that with a focus on addressing healthcare disparities and health equity. And I want to just take a second to shout out our incredible colleagues like Laura Gottlieb and the group at Siren, who research health-related social needs and who have a very nuanced view of their role in equity and in the healthcare system. All right, so given that, what should we do? And I'm going to talk about 4 things. First, I think we need to focus on our lane. And what is our lane? The delivery of healthcare services, treatment and prevention of disease. And I'll talk a little bit more about reorganizing healthcare delivery, which it may include the integration of social resources. I think that as institutions and as community members, it's important to advocate for increase in resources for both people who are sick and people who are well, for individual patients and for communities. And I think we should continue our anchor institution efforts. So which UCSF Health, for example, does. What are anchor institution efforts? They're efforts in purchasing and training programs and et cetera that really can have the potential to influence the social determinants of health. One study that looked at 3 years between 2017 and 2019, looking only at public announcements, found that health systems spent $2.5 billion in investment in social needs. This is quite substantial. So I don't know if you can see this, but for example, in Ohio, the Cleveland Metro Health System spent $60 million in the creation of new housing and an economic opportunity zone. Johns Hopkins spent over $50 million in procurement from local communities and in hiring people from the communities. And there have been a series of other programs. You can see that in things like healthcare and housing, transportation, which unfortunately has not resulted in improvement in healthcare utilization. And of course, the many different ways in which people are trying to address food insecurity, including the provision of vouchers for fruits and vegetables, for example, in the ESF programs, which help local community businesses and do result in more consumption of fruits and vegetables. So again, lots of great things going on. So let's talk now about focusing on healthcare disparities reduction. And I want to start by saying it is absolutely possible. Here is data from ARC looking at reduction in inpatient deaths from heart attacks by race ethnicity. And what you'll see is that everyone got better. And the disparities are still there, but almost eliminated. This is This is an extraordinary feat. This is data up until 2013. Here is data on outpatients with chest pain who receive appropriate fibrinolytic therapy within 30 minutes. And you can see that there hasn't been a lot of improvement, and there has been more splaying with the pandemic, more increase in health disparities. And you'll see, actually, I think in JAMA this week or last week, there are a number of articles about MIs during the COVID pandemic and increased disparities with them. But nonetheless, acute cardiac care is a huge success story where most people are getting much better care and disparities have been thoroughly reduced. So what drove that? It wasn't doctors being more woke. It wasn't health-related social needs screening. What did that? And what did it was a combination of things. One, remember that acute MI care is limited. It starts and stops, and it usually is about things we do to patients as opposed to things that we do with patients, as in the treatment of chronic disease. But there were 2 decades of research that examined every part of this problem, from the moment someone first experienced chest pain, and what happened how long it took the ambulance to get there, what happened in the ambulance, whether or not the ambulance should stop at the local hospital or should go on to a regional cath center, and so on, which ended up creating clear guidelines with well-established clinical norms, and ended up even with a reorganization of the health system across health systems with regionalization and in ambulance triage. It was done through done through clinical guidelines committee and the usual ways in which we make change. But one of the things that was particularly, I think, noteworthy was the involvement of the American Heart Association and other NGOs in pushing for these guidelines and in drawing attention to these stress. So again, a shining example of we can do better, we have done better, we do better. And one way to look at that is that here is a scenario in which quality improvement, these are 2 populations, both populations got better and the disparity closed. As opposed to this scenario, which is flu shots, for example, where both populations do better, but the disparity stays the same. Or this scenario where one population, where again, both populations improve, but one improves more, which is usually the case when you introduce a new technology or new medication. All of which is to say, generic quality improvement can bring a lot of different impacts onto the equity form. So let's switch to chronic disease, the area where we do much less well. And here is the example from congestive heart failure. And again, people are having fewer admissions for congestive heart failure, but the gap here, this is the African-American population, remains quite big and in fact, technically has widened. Or let's talk about something relatively straightforward, hypertension control, the most important modifiable factor in both cardiovascular disease, as you all know, heart failure and stroke. And hypertension prevalence is about almost half of US adults, 48% of adults. Only about 60% are aware of their condition. About 50% are treated with at least one medication. And here in the green is 2023, only 20% had a controlled blood pressure of under 130. Now, this is NHANES data. It represents the population as a whole, and that's very different from the numbers that we see in high-performing healthcare systems. Let me give you an example. This is Kaiser data, in which Kaiser in 2001 had a rate of hypertension control around 40. And by 2009, had a rate of hypertension control over 70%. And I haven't shown the disparities here, but they had disparities reduction of 70%. So a hugely successful program. Well, how did they do it? They put in a multimodal approach. They had physician-led educational programs on treatment identification. They had care teams with defined roles. They redesigned care delivery to increase access. They put forward culturally tailored tools for self-management and so on. And they have been able to sustain and actually increase their level of control since then. Here's some data from UCSF that from the pandemic, and you'll see this line here is all patients. This line here is African-American patients. You'll see that during the pandemic, the proportion of people with controlled hypertension, of course, got worse as we were unable to see people. And then as we were coming out of the pandemic, a hypertension disparity reduction program was put into effect that resulted in much rapid increases in the African-American population with hypertension. And that included things like targeted robocalls, pharmacists, registries, a focus on rescheduling people with missed appointments, and so forth. Again, a multimodal approach resulted in good success, though my understanding is that it's been difficult to scale this program. So in other words, one of the things that we need to do is improve chronic disease for everyone. And that means a real recognition that the quality of care that we provide is just not so great for most people with chronic disease. If 30% of people, even in a high-performing healthcare system, don't have their hypertension control. And it isn't that those 30% are homeless and have health-related social needs. It has something to do with the fact that we're somehow providing ineffective care. So why is this? There are many reasons. Partly, or predominantly, one would argue, is the underinvestment in primary care. In the US, about 8% of the dollar, of the healthcare dollar, goes to primary care. And that's just way too little. The other thing is that until recently, primary care, outpatient care, was stuck in a formula in which we do the same thing for different people. If someone is admitted to the inpatient service with pneumonia, maybe in 2 days they get better and they get discharged. But some people, hey, maybe they need 4 days. And we don't say, oh, 2 days, time to go. We say, no, we'll keep you for 4 days. We titrate the amount of care that we give to their need. It's clinically obvious. We do it for every disease. But we don't do it in the outpatient setting, where we see people for the same 15 or 20-minute visit, regardless of whether there's someone presenting with only hypertension or someone presenting with 5 clinical concerns. And our only option in the primary care setting is to make another appointment for them down the line. 4 months later, we'll see them again. And 4 months after that, we'll see them again. And that's been the biggest sort of, it has needing to change those and creating clinical programs that break that pattern. Hasn't happened throughout the country, though certainly here and at the General and VA, we have plenty, we have now ancillary programs. One last example of a targeted QI effort, and that is community health workers. So community health workers, you will know, these are lay people who extend the healthcare team usually into the community. And they typically do 2 things. They provide patient-centered education, and they also provide resource navigation. So here is when a community health worker will go out, they'll meet with a patient who has diabetes, they'll determine the patient has food insecurity, and they'll connect them with resources. And these community health workers have been studied in multiple disease targets, such as hypertension, diabetes, HIV, and have been found to be particularly effective in the Latino immigrant population with diabetes, where language barriers frequently complicate access both to resources and to efficacious healthcare. And we know a fair amount about what makes community health workers. There's over 200 randomized trials of this. There's a Cochrane review, there's multiple systematic reviews, and there's enough that Medicaid now pays for community health workers throughout the country. And in California, community health workers are now being used, particularly in Southern California, to improve chronic disease care in various disease states. And we are not seeing them used and those encounters are billed to Medicaid. Unfortunately, Medicaid billing is not high enough in expensive Bay Area to make having community health workers self-sufficient, a standalone program. But again, why bring this up? In this argument, it's a targeted QIM program that can be very useful. So with that, what are then, if we're saying, well, we don't like this and we don't like that, what are the things that we do like? We think we should be doubling down on reorganizing healthcare services. And what that means is implementing local quality improvement programs that prioritize equity and implementing local clinical guidelines to reduce the variation of care. And it also means allocating resources using what people now call targeted universalism. We have a universal goal. Everyone should have their blood pressure control, but we target our resources in such a way that people who need more get more, which of course makes a lot of clinical sense. When accompanied by strengthening of primary care and other support for decision-making, this can be a very powerful combination. So why don't health systems do more of this if the research is there and so on? Well, partly because few health systems are incentivized to do this. One of the things that is often required is leadership to see this as an important problem. We give an example here. In federally qualified health centers are required to have the majority of their board of directors be representative of health center patients. I don't think that we're going to move to a system soon in which, for most health systems, half the board or even a third of the board are patient representatives. But it does show that one can have a different structure of leadership that could be useful. What some institutions have done is that they've created local leadership supports. And one is equity performance dashboards. My understanding is that UCSF Health, for example, is now creating an equity performance dashboard. Some have put in equity leadership at the C-suite level and given those people more resources. There have been equity incentives for clinical leadership and staff, just as in the same way that there can be incentives for other clinical measures. And then training, targeted training to staff that focuses on very specific skills that allow them to do their job better. The last thing is payment policies, regulations, and accountability metrics. And here, unfortunately, there are a few bright spots, which I want to list, but the majority of the news is, as you well know, that our current payment system does not support quality of care and does not support equity. However, Blue Cross Blue Shield of Massachusetts has started a pay for equity performance program where they incentivize reducing disparities. The VA has a pay for performance program, which they've put in place for improving blood pressure among Black patients with hypertension. There's been a push to create metrics that at least people could, on a voluntary or non-voluntary level, report out. And a number of the quality organizations have come together to try to create health equity metrics. The most important, to my mind, development has been Medicaid waivers. And there are a number of Medicaid waivers right now, the 1115 waivers, which different states are using to provide upfront funding. If I go and say, listen, we need to a health system, we really need to do something to improve equity in diabetes outcomes. And they say, oh, well, what would she do? And I say, no problem. We have lots of research on this. We know that putting pharmacists in place will really help. Won't be a cure-all, but it'll really help. So let's put some pharmacists there. They'll say to me, well, we only have X amount of pharmacists. They're very busy. they're doing other things. You want me to take them from the area that they're doing things in to put them into this area. That's not going to work. And hence flexible upfront funding is so useful. And this is where the Medicaid waivers come in. California has the Medicaid waiver that's now called the CalAIM program. And that provides more funding for enhanced care management, for community support, for capacity building for providers, and all sorts of things. So it's really a very useful program. And I wonder how long it will stay. And then finally, what some people are experimenting with, like CMMI, the Center for Medicare and Medicaid Innovation, has created accountable care organizations programs where they increase the funding for every member that is in the top decile of social vulnerability. So if you have more members with more social vulnerability, you get more payment. And that would and that has been going on to see whether or not that can result in better equity. Unfortunately, last week, CMMI announced that for those programs that they should stop reporting on patient race and gender and language. And so I don't really know how that program can possibly go forward. So where do we go from here? I do believe we should continue to screen and address for health-related social needs, but I think we need to double down on our focus on, are we organizing the resources we currently have to the best effect for all of our patients? And finally, I think we need to think through allocating more resources to areas and people with more needs and less to those with those. So with that, let me stop here, because I really have wanted to have a conversation with Dr. Wachter and get some questions and so on. Thank you very much.
Thank you, Alicia. That was terrific and provocative and incredibly timely. Let me start with a few. How do we know that? I'm quite concerned, even before the last few weeks, about the effector arm. Like, all right, we're collecting these data that we didn't used to collect. It sometimes feels like it's going into a black hole. That okay, we now know that patients have certain social determinants. We understand that those are ultimately related to their outcomes. As you say, we're collecting them within a health system. You mentioned that somehow it's bidirectional, or somehow it goes out to somebody somewhere. But is there decent evidence that they are actually making a difference in patients' outcomes?
Very little, very little. And again, different health systems are doing this differently. I can give you one example where it seems to be making a big difference, though they eliminated screening, and that is at San Francisco General Pediatrics. They no longer screen families for food insecurity, because when they did that, the families would say, no problems here, no problems here. And instead, what they've done is that they've gone directly to saying, would you like help enrolling for SNAP, which is a food program? And people are like, yes, I want that help. And so they've gone directly to the effector arm. But in most places, the data are only just coming out around what these programs can help with or cannot help with, and also how much would it really cost to create a program where there could be good linkage to a community-based organization, and that community-based organization has access to the resources. So I don't think that, none of us think that the issue in San Francisco is that the city government or the state government doesn't know that we have a lot of homeless people. Everyone knows that, right? So here, screening people for homelessness is helpful. On some level, it may signal people who may need more help. I have patients, for example, who are getting navigation for their cancer because they're experiencing homelessness. But I don't think that sending them to a community-based organization to get help with their housing is helpful at all.
And a lot of this boils down to accountability. So I guess one of the questions for the healthcare delivery systems is, okay, you're going to measure, maybe we're going to stop measuring and we'll have to see how the next several years plays out, but you're going to measure my performance on equity, and yet I don't have the levers to improve equity in that so much of them exist outside our walls. And periodically you'll hear about a health system building housing, and it's like, we don't even know how to do healthcare. What makes us think we're going to be good at building housing? So and then you have this other issue of accountability where some of the equity differences probably are patient related in a way, and that doesn't let the healthcare system off the hook, because it means you've got to probably do some special things to make sure people are able to get their medicines, take their medicines, come to their appointments, whatever. But how do you respond when people say, you're holding me accountable for equitable outcomes, and I really don't control many of the levers that relate to those outcomes?
Well, fortunately, no one is holding us accountable. They're holding us accountable for screening.
Mm-hmm.
Is the checklist filled out?
Yeah.
Do you have housing security? Check. Do you have food insecurity? Check. No one is holding us accountable for actually anything beyond the screening.
Mm-hmm.
So it's all, to a certain extent, it's all a little bit of a shell game.
Yeah.
It's saying, wow, we have disparities. The problem is not in the healthcare system side. It's out there in society. It's really unfortunate. We should screen people for these problems.
Yeah.
There's no accountability. And yet, this has been the consensus of what we need to do. In the last decade, this has been the consensus of what we need to do. And that's why it's frustrating for people like me who'd rather talk about how do we treat hypertension, which is really hard, and let people who know about it talk about how to solve housing problems, which we didn't study.
Yeah. Yeah, it's even harder kind of at a macro political level, because the point you made about how the aggregate amount of spending in many other, for example, European countries on health plus social determinants is about the same. Ours is very skewed toward health.
Yeah.
We're part of the problem, probably, because if you said to all of us, including, I'm guessing, the folks at San Francisco General, okay, we hear you, we're going to cut your budget in order to make sure that we've got the money to do all these other things, and we're going to fund social organizations better, but the only way we're going to find that money is pulling it out of your budget. My guess is that all of us would fight that.
Of course. And
because we see the unmet needs that we have in our system. So it's hard to figure out how you get around that conundrum.
I think that's right, but I think it's because we look at it as a zero-sum game between health services and social services. And in fact, that there are plenty of other resources in society that could be moved in order to do that funding. Mm-hmm. So I do think that the Medicaid waivers are a good step so that people can say, okay, right now, what exactly do our patients need and how can we help using healthcare dollars? But at the end of the game, it cannot come from the healthcare system. It eventually, it just can't.
When you talked about the Medicaid waivers, Medicaid is obviously an interesting program, and that it's both federally and state funded. And you said, kind of almost under your breath, I'm worried about the California program. Maybe it's going to go away, even though it looks like it's working. If the feds cut what they're putting into Medicaid, does that end programs like that, or the state can pick it up, or how do you think those all play out?
Yeah, that's a great question. So there's going to be tremendous pressure to cut Medicaid costs. The people, they want to cut $900 billion in Medicaid over the next 10 years. That's the goal. And there are many avenues that people are currently exploring to do that. One of them, of course, is block grants, where you give a state a certain amount of money and you say, like, that's it. Another one that people are doing is thinking about capping the amount of dollars per enrollee. So you have more enrollees, you cap them. But the ones that seem to have the most attraction right now, for moderate Republicans who will be key to this, are two programs. One is a work requirement, and the other one is keeping Medicaid only for citizens, which means eliminating permanent residents' access to Medicaid. So the work requirement, you can say, well, how does working help Medicaid cut costs? after all, the majority of people on Medicaid who can work already work. And the reason is that it sets up friction in the system and causes disenrollment. And so I think for red states, it'll be a way in which people disenroll from Medicaid. For blue states, it'll make it easier to document your work and maybe disenroll fewer, but there'll be disenrollment on that. But it sounds appealing, right? If you're getting Medicaid, you should work. The second thing is that permanent residents are now entitled to apply for Medicaid if they've been in the United States, if they've been permanent residents for 5 years. And now they'll move to eliminate that. And that will also probably be hugely popular. Won't affect us in California, at least for now, because California has been paying for undocumented people to have access for Medicaid if they meet using only state dollars if they meet requirements. So to make a long story short, I think that there's going to be tremendous pressure on these programs. There'll be tremendous pressure on California's programs. We're going to have to make up a lot of federal deficits and a lot of federal changes. And I don't know what will happen with programs like CalAIMS.
Let me ask one more, then we'll open it up. When we were coming in, you mentioned that you're on a number of prominent national organizations that are discussing this. I'm sure in your day job, discussing everything that's going on. National organizations, the U.S. Preventative Services Task Force, some important roles with the NIH, with the National Academy of Medicine, ABIM. Without revealing any behind closed doors conversations, what's the general flavor of these conversations? There's some thought, I'm sure, of, let's just sort of change the way we label things and try to do the same important good work, but not have anything with a word that can be caught in a search. And there are others who probably are saying, let's just double down, let's do the right thing. And others are saying, let's just acquiesce and, this is what the country voted for, and let's just go along, get along. First of all, what do you think the right thing to do is? And second of all, what are you hearing?
I think, I don't know what the right thing to do is. I think we should only pick fights where we have even a small chance of winning, and only if the fight is really necessary. And for a lot of these things, word choice and so on, it may not be so necessary. In general, what I'm feeling, what I think people are saying is, let's keep doing more or less what we're doing without attracting undue attention. And I think that there's this feeling that right now it's all about breaking eggs, and it doesn't make any particular sense. So let's just stay out of the firing line, see where it settles down, and then we can come up with a strategy. I've been surprised, however. There are organizations like the Howard Hughes Medical Institute, which had made $1 billion commitment to DEI STEM, to preparing high school students and undergraduates in the sciences. And they just canceled their $60 million effort for this year from one minute to another. And that was really surprising. They're a private organization and they canceled that. There are other organizations that you would think would be able to have some distance from the federal government, and they're going ahead and canceling their efforts. I don't know if people know, but the health data, the matriculation data for the medical schools came out a few weeks ago. We're seeing an 11% drop for Black students nationally, and a 10.9% drop for Latino students nationally in the 2024 matriculation data. So that is the result of the 2023 SCOTUS decision. So already we're seeing a decrease in what's going to be the next classes. If we follow what happened in Prop 209, it'll decrease even further for the next few years before medical schools work out a way to rebound.
Great, thank you. Let's throw it open to folks. Yeah.
I had a comment about ride share in terms of reducing access barriers, but it hasn't been successful. Any opinion on why?
I think the question is that I mentioned that rideshare has not been very successful. And I think that there's a few reasons for that. I think that the answer is I don't know why. I haven't seen drill down data on why it hasn't been very successful. My personal opinion is that we do need easier ways for patients to interact with us. And this is where, telehealth for equity would come in. It is really hard for a patient who lives far away to come in and see us for their, let's just check your blood pressure and see whether or not we need to titrate you. And so I think some of it is that, and that patients are sort of voting with their feet. It's a little bit like asking me, why don't you go to the gym, Alicia? And I'll say, oh, I don't have time. But the real reason probably isn't time. It's probably a lot more complicated than that, having to do with a good, ultimately wrong-headed, but a sentiment that I'm making about, is it worth it to me? So it's unfortunate that those haven't worked out.
Dr. Lowe.
Dr. Fernandez, thank you very much for such a stimulating and thoughtful and provocative talk. I want to really try and push you into February 2025 and beyond. So the subtitle of your talk is focusing on health equity. Well, that's a bad word now. It just got deleted from all the federal websites. You talked about our poor outcomes for things like hypertension, and also mentioned, well, and there are even worse outcomes for some population subgroups. Is there a way to reframe the equity message by saying, look, we do a great job of saving people once they had a heart attack. We don't do such a great job treating the outpatient conditions that we know lead up to a heart attack. And you could do diabetes care as well. Is there a way to reformulate the ideas that you and others have worked on without using forbidden terms?
I think so. I think this is where the vocabulary of targeted universalism comes in. We need to control hypertension in everyone. But I think targeted universalism won't work unless it's accompanied by careful distribution of resources. It worries me a little bit. Like I was at a health equity sort of meeting last week, and people said we need to control hypertension in everyone. Absolutely, and so they said, so we should stop doing those programs. I think we can rename those programs. We can call them programs for people with certain parameters of blood pressure. But I don't think we can stop doing those programs. I think if we do, then we'll end up in a scenario where we don't make progress.
I mean, do you see any conflict between that answer and way of thinking and the point you made about the progress we've made in acute MI? That really, there was one approach to that, and we did it with everybody. There may have been some tweaks that related to some social determinants, but by and large, it was sort of formulaic. And it worked. Is it just that the setting and the disease and the time limitation is so controlled and so different that it's not the right model for everything else?
When someone comes in with an MI, we were all residents. The patient comes in, we barely glance at the patient as we rush to the EKG. We do to the patient in acute MI. And then once they're inpatient, we're doing. And that works great. In chronic disease care, we have to do with the patient, and we have to do with the patient over years. And that is really difficult. I should go to the gym,
You've mentioned that twice. You really should, I guess.
Really should.
I think we have a question from Zoom.
Yeah, thank you. Some great questions in the chat. One which you sort of addressed already in terms of the verbiage, calling these various programs. But I know there are a lot of sort of young and rising physicians who are watching this and may feel understandably overwhelmed kind of by the landscape and all the things that you talked about. And I was wondering if there were one or two sort of pointers that you might give to people, like, what can I do? I'm a med student, I'm a resident, like, what would the next steps look like?
Great question. I think for people who want to do research, there's research opportunities galore. But what about if that's not what interests you?
Just before you leave that,
Yeah.
we have plenty of young people in the department who want to do research in health equity.
Yeah, they're not going to. They're not. I think that's. I think that's terrible. I think that if you want to do research in controlling research for hypertension control, you'll have to call it something like getting to universal hypertension control. If, however, obviously, if you want to do research on transgender, because that's where your heart is, then that's not a happening thing. It looks like it's not a happening thing. We'll have to see. But I think that for people who don't want to do research, I think that instead of looking for things outside the healthcare system, they should look for more opportunities within the healthcare system, ways to do things, even if they're only pilots, in which we can be more efficient, more patient-centered, and get different people what they need, with some people needing a little and some people needing a lot. And I think that's really hard because it always means we have to move resources around. And that's why, at the end of the day, health equity demands so much leadership. We saw that during the pandemic, when from the chancellor on down, there was a lot of leadership. Dr. Wachter's leadership. There was so much leadership invested in doing the best job we could, and we made lots of changes in a very short period of time. We don't have that same urgency with this.
Dr. Critchfield.
Thank you so much, Dr. Fernandez. I'm going to try, I guess, fuse a couple things. One is up and coming folks, but also what's the difference between acute MI and long. And I'm also recognizing many of us in this room who are physicians take care of adults, like chronic hypertension. When you start talking about upstream, like what does the conversation look like to say early childhood development?
Yeah.
What do we start talking about? People are making decisions about food and exercise and smoking or not smoking. Not that we have to save them later in the MI model, or when they come to see you in RFPC, like, I'm going to start a second drug for you to get your blood pressure down, but they're already beginning to understand. And those take 25 years, 15, 20 years, because I think the distinction is personal decision-making. So what's our opportunity now to kind of talk about these things that are happening, and how do we bring that to the public? And maybe pediatricians, maybe that's the answer for up and coming doctors. Be a pediatrician. You know, I'm being provocative, obviously, Bob's standing here.
I think you're bringing up really great points, and it's not an area where I have a lot of expertise, but it is absolutely true that the social determinants of health really shape the pediatric environment. But the pediatricians are doing great things with that. And we, for example, in one organization I work with at the Latinx Center of Excellence, we've partnered with summer camps in order to increase nutrition and physical education and so on, precisely because we believe it's so important. And we have medical students and others working on that. So it's a drop in the bucket, but there's lots of things people can do.
What do they do in Sweden?
They bicycle.
We now have a health secretary who has unusual views about vaccines, but also has views that I think you could have reasonable arguments about the amount of energy and focus we put on wellness and on staying healthy versus on acute care. What do you think of that? And do you think there's anything good that may come out of that?
I hope so. I think that I agree with Mr. Kennedy on the importance of chronic disease, on the importance of prevention, on the importance of improving the food supply, and so on. And I hope that that creates more funding opportunities for my colleagues who work in those areas, for people who doing works in pediatrics and so on. I hope so. Right now, we're in the destruction phase. And what will actually shape out once they start thinking, okay, we are going to keep this, we're going to not keep that, remains to be seen. And unfortunately, our work in academia, or simply as physicians, we have to work with federal agencies. And one of the things that's very unfortunate is if great people leave federal agencies, the quality, they have such high quality people, of those people leave, that will make it harder.
We give you a chance in the last minute to reflect a little bit about your own position and career in this moment, and how you wake up in the morning and get through your day.
I want to go to the gym. Yes, I know.
There's that.
I'm too busy I'm too busy waking up at night, and I wake up at night and I reach for my phone to say, what horrible thing has happened in the 4 hours I've been asleep?
I'll push back slightly because I'm guessing you did not go to the gym 3 months ago either.
didn't.
Okay, so.
No, I'm a chronic non-gymmer, Roland. But what I do think is that these are hard times, and they remind me. I grew up in Argentina, and you may know that Argentina had also very difficult military government, very difficult time when I was a teenager. And one of the things I learned about was being very scared. And there we were physically scared. 30,000 people were killed. And here we don't have that fear. And I'm even very lucky. I don't have the fear. I don't worry that I'm going to lose my job, for example. But what I have, what reminds me of that time is this anxiety of thinking the way I thought the world was going to work is not the way the world is working. And I can't predict things. And the things that I knew to be true may no longer be true. And I think we're looking at the relationship between, that's why this whole term of constitutional crisis is so important. I don't think it'll happen. I think the Supreme Court will back down. But if the executive power defies the Supreme Court, they can just say, yeah, you and who else is going to enforce that ruling? So these are the sorts of things that make people, perhaps mainly immigrants who come from other countries and have seen this destruction of democracy, makes me wake up at night, even though I don't think we're there. It's that feeling.
Thank you for sharing that, and thank you for sharing your thoughts with all of us. It was terrific.
Thank you very much, Dr. Orfis.